You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about patient-prosthesis mismatch and prosthetic valve stenosis, including prosthetic valve thrombosis, which I think is a very interesting topic in cardiology. We'll talk about the definitions of patient-prosthesis mismatch and prosthetic valve stenosis. We'll give you a systematic approach to diagnosing each condition, and then we'll talk about management of patient-prosthesis mismatch, management of prosthetic valve stenosis, and management of prosthetic valve thrombosis. So let's start with what these are. What is patient-prosthesis mismatch, or PPM? This is when the size of a normally functioning prosthetic valve is too small for the patient's body size and cardiac output requirements, thus resulting in abnormally high transprosthetic gradients. Because patient prosthesis mismatch involves a discordance between the effective orifice area of the prosthetic valve and the patient's body surface area, patient prosthetic mismatch can be identified using the index valve EOA, the index valve effective orifice area. For aortic valve prosthesis, index EOA of more than 0.85 centimeters square per meter square is mild or not clinically significant. Less than 0.85 centimeters square or meter square inclusive is moderate patient prosthetic mismatch, and less than 0.65 centimeters square per meter square inclusive is severe patient prosthetic mismatch. For mitral valve prostheses, the numbers are 1.2 and 0.9 instead of 0.8 and 0.85 and 0.65. So to spell that out fully, for mitral valve prostheses, index EOA of more than 1.2 centimeters square per meter square is mild or not clinically significant, and less than 1.2 centimeters per meter square inclusive is moderate patient prosthetic mismatch, and less than 0.9 centimeters square per meter square inclusive is severe. Patient prosthesis mismatch is considered a non-structural valve dysfunction because it is not an intrinsic dysfunction of the prosthesis. Moderate patient prosthesis mismatch occurs in 20 to 70% of aortic valve replacement, and severe patient prosthesis mismatch occurs in 2 to 20%, depending on which studies you look at. TAVR has a lower incidence of patient prosthesis mismatch than SAVR. Among transcatheter valves, self-expanding valves with a supraannular design have a lower incidence of PPM than balloon expandable valves, although there is a higher incidence of pacemaker requirement and paravalvular regurgitation. Patient prosthesis mismatch results in worse New York Heart Association functional class and exercise capacity, higher rates of heart failure rehospitalization, and reduced survival after SAVR compared to patients with no patient prosthesis mismatch. How about prosthetic valve stenosis? Prosthetic valve stenosis refers to the narrowing of the aortic valve orifice or mitral valve orifice after valve replacement surgery, leading to high gradients across the valve and impaired blood flow. Prosthetic valve stenosis can be caused by structural valve deterioration, pannus formation, or prosthetic valve thrombosis. Structural valve deterioration refers to degeneration of the valve, for example, calcification or tissue stiffening. Pannus formation refers to growth of fibrous tissue around the valve, which can obstruct blood flow. Prosthetic valve thrombosis refers to a clot which can obstruct valve motion and mimic stenosis. Please note that prosthetic valve thrombosis can lead to either stenosis, when the thrombus obstructs leaflet motion, or valve regurgitation, when it causes impaired leaflet closure. So, not all cases of prosthetic valve stenosis are due to thrombosis. Stenosis can also occur from structural valve deterioration, particularly in bioprosthetic valves such as calcification or tissue stiffening, or from fibrotic pannus formation, which is growth of fibrous tissue around the valve that obstructs blood flow. Bioprosthetic valves, while less prone to thrombosis compared to mechanical valves, are increasingly being diagnosed with subclinical thrombosis due to the growing use of CT imaging and the rising number of bioprosthetic valve implants, including TAVI procedures. Thrombosis of bioprosthetic valves is most frequently observed within the first 3 months after implantation, but it has also been reported to occur much later, 1 to 2 years post-implantation, with the longest recorded interval being 6.5 years, according to the guidelines. According to the 2020 AHA-ACC valve disease guidelines, in patients with suspected mechanical or bioprosthetic valve stenosis, TTE and TEE are recommended to diagnose the cause and severity of valve obstruction, assess ventricular function, and estimate pulmonary artery systolic pressure. That is a Class 1 recommendation. In patients with mechanical valve stenosis, fluoroscopy or cine-CT is recommended to assess motion of the mechanical valve leaflets, Class 1. In patients with bioprosthetic valve stenosis, 3D TEE or 4D CT imaging can be useful to rule out leaflet thrombosis, Class 2A. In patients with suspected bioprosthetic valve thrombosis, 3D TEE or 4D CT imaging can be useful to rule out leaflet thrombosis, Class 2A. In patients with suspected mechanical prosthetic valve thrombosis, urgent evaluation with TTE, TEE, fluoroscopy, and/or multidetector CT imaging is indicated to assess valve function, leaflet motion, and the presence and extent of thrombus, Class 1. Now we can develop a systematic approach to diagnosing patient-prosthesis mismatch and prosthetic valve stenosis. Understanding how to diagnose patient-prosthesis mismatch versus prosthetic valve stenosis is one of the most tricky topics, in my opinion, on the general cardiology board exam and the echo board exam. Let's start with how you use DVI, AT, and jet contour. When the peak prosthetic aortic jet velocity is more than 3 meters per second, your job is to figure out if this is prosthetic valve stenosis, patient-prosthesis mismatch, or high flow state. So that's what you start with when the peak prosthetic aortic jet velocity is more than 3 meters per second. One of the key parameters you look at is the Doppler velocity index, or DVI, which is the ratio of the velocity, or VTI, of the LV outflow tract flow to the velocity, or VTI, of the transprosthetic flow. In patient prosthesis mismatch, the DVI, the Doppler velocity index, is usually 0.30 to 0.35. Although it can also be 0.25 to 0.29, which is when you need to rely on the acceleration time and the contour of the transprosthetic jet to differentiate it from prosthetic valve stenosis. In prosthetic valve stenosis, DVI is less than 0.25 if the stenosis is severe. But it can also be 0.25 to 0.35 when the stenosis is moderate, which is when you need to rely on the acceleration time and the contour of the transprosthetic jet to differentiate it from patient-prosthesis mismatch. Acceleration time, or AT, also abbreviated as TPV, time to peak velocity, is the time from the onset of flow to the time of peak velocity. Acceleration time should be less than 100 milliseconds. As obstruction increases, the acceleration becomes more prolonged, and the contour of the transprosthetic jet becomes more rounded with a more delayed peak in systole, and the ejection time also becomes more prolonged. If the contour of the transprosthetic jet is triangular and peaking early in systole, corresponding to a normal acceleration time of less than 100 milliseconds, it could either be normal prosthetic valve function or high flow state if the index EOA is normal, or patient prosthesis mismatch if the index EOA is abnormal. If it is rounded and symmetrical, i.e. peaking late in systole, corresponding to a prolonged acceleration time of more than 100 milliseconds, it is likely prosthetic valve stenosis. If your transprosthetic jet contour is rounded and symmetrical, peaking late in systole, but your Doppler velocity index is closer to the upper end of 0.25 to 0.35, then this could be prosthetic valve stenosis with subvalvular narrowing, underestimated gradient, or improper LVOT velocity. In this case, improper LVOT velocity may occur if the PW Doppler sample is too close, i.e. not apical enough to the valve. If the Doppler velocity index is less than 0.25, but the transprosthetic jet contour is triangular and peaking early in systole, corresponding to an acceleration time of less than 100 milliseconds, it may be improper LVOT velocity. In this case, improper LVOT velocity may occur if the PW Doppler sample is too far, i.e. apical, from the valve. An index EOA of 0.65 centimeters per meter square or less occurs in both severe prosthetic valve stenosis and severe patient-prosthesis mismatch, and an index EOA of 0.66 to 0.85 centimeters square per meter square occurs in both mild to moderate prosthetic valve stenosis and moderate patient-prosthesis mismatch. Prosthetic valve thrombosis does not always result in obstructive symptoms or a large increase in gradient. Embolism may be the sole presenting feature. You need to suspect thrombosis when a prosthetic valve patient has new onset heart failure or change in dyspnea, thromboembolic events, or a change in murmur or muffling of closing sound. The overall approach for assessing aortic prosthetic stenosis versus patient-prosthesis mismatch, which is different from the mitral one, is as follows. Apart from the maximal prosthetic aortic jet velocity being more than 3 to 4 meters per second, there are a number of other parameters we look at next. If the mean aortic prosthetic pressure gradient is more than 35 millimeters of mercury, and note that this is different from the 40 millimeters of mercury of mean aortic pressure gradient that we look at for non-prosthetic valves. So again, if the mean aortic prosthetic pressure gradient is more than 35 milliliters of mercury, the Doppler velocity index, or DVI, is less than 0.25, the EOA is less than 0.8 centimeters square, and the acceleration time is more than 100 milliseconds, then that is a slam dunk diagnosis for prosthetic aortic valve stenosis. If these parameters are intermediate, with a prosthetic aortic jet velocity of 3 to 4 meters per second, mean aortic prosthetic pressure gradient of 20 to 35 millimeters of mercury, Doppler velocity index of 0.25 to 0.35, and EOA of 0.8 to 1.2 centimeters square, then the flowchart that I just described to you in the above section should be used to tease apart patient-prosthesis mismatch, mild to moderate stenosis, and high flow state. Okay, that's when you go through that kind of flowchart that I talked about. The overall approach for assessing mitral prosthetic stenosis versus patient-prosthesis mismatch is as follows. When it comes to mitral valves, the same variables are examined as in aortic prosthetic stenosis versus patient-prosthesis mismatch, except we look at the pressure half time, PHT, instead of the acceleration time. If the maximal anterograde velocity through the mitral prosthetic stenosis is at least 2.5 meters per second, and so you recall this is different from the 3 to 4 meters per second for aortic valves. So if the maximal anterograde velocity through the mitral prosthetic stenosis is at least 2.5 meters per second, the mean pressure gradient is more than 10 millimeters of mercury. And recall this is in contrast to the 40 millimeters of mercury we use for aortic valves, or 35 for prosthetic aortic valves. And the effective orifice area is less than 1.0 centimeters square, in contrast to the 0.8 centimeters square we use for prosthetic aortic valves. And the pressure half time is more than 200 milliseconds, then that is a slam dunk diagnosis for significant mitral prosthetic stenosis. So let me say those numbers again. If the maximal anterograde velocity through the mitral prosthetic stenosis is at least 2.5 meters per second, the mean pressure gradient is more than 10 millimeters of mercury, the effective orifice area, or EOA, is less than 1.0 centimeters square, and the pressure half time is more than 200 milliseconds, that is a slam dunk diagnosis for significant mitral prosthetic stenosis. Now, if the maximal anterograde velocity through the mitral prosthetic stenosis is less than 1.9 meters per second, the mean pressure gradient is less than 5 millimeters of mercury. If the effective orifice area is more than 2.0 centimeters square and the pressure half time is more than 130 milliseconds, that is a slam dunk diagnosis for normal prosthetic mitral valve function. For the values in between these cutoffs, it could be possible stenosis, patient-prosthesis mismatch, or high flow. Unlike in aortic prosthetic stenosis, there's no flowchart for sorting between the conditions easily, partially because there's so much variability in what is normal. For example, St. Jude bileaflet mechanical mitral valve prostheses can have mitral valve pressure gradients up to 12 millimeters of mercury and mitral valve peak velocities up to 2.4 meters per second and still be functioning perfectly normally. In uncertain cases, it is suggested that other diagnostic approaches be used, such as CT imaging or cardiac catheterization. Note that while the DVI, Doppler Velocity Index for prosthetic aortic valves, can be done as a ratio of velocities or a ratio of VTIs, depending on which textbooks you go by, the DVI for prosthetic mitral valves is only done by velocity time integral instead of a ratio of velocities, according to every textbook that I have laid my hands on regarding this topic. So VTI of the prosthetic mitral valve over the VTI of the left ventricular outflow tract, less than 2.2 is normal. 2.2 to 2.5 suggests possible mitral prosthetic stenosis, and more than 2.5 suggests significant mitral prosthetic stenosis. This is a VTI of prosthetic mitral valve divided by VTI of the left ventricular outflow tract. Now that we have diagnosed this, how do we manage these conditions? We'll start with management of patient-prosthesis mismatch, then we'll go over management of prosthetic valve stenosis, then prosthetic valve thrombosis. For mild to moderate patient-prosthesis mismatch, it is often conservative management with optimization of medical therapy, including afterload reduction with ACE inhibitors or ARBs, diuretics for symptom control in the case of heart failure, and close monitoring of symptoms and echocardiographic follow-up. But if you have severe patient prosthetic mismatch, especially if it is symptomatic, or if it's lower levels, mild to moderate with symptomatic, then you need to consider re-intervention if the patient remains symptomatic despite optimal medical therapy. This could be a redo valve surgery with a larger prosthetic valve, aortic root enlargement or annular enlargement techniques during redo surgery, or transcatheter valve-in-valve procedures like a valve-in-valve TAVR is an emerging option for patients with severe patient prosthetic mismatch who are not suitable candidates for repeat surgery. Now, how about management of prosthetic valve stenosis? When deciding whether prosthetic valve stenosis should be treated with reoperation or valve-in-valve TAVR, several factors need to be considered. First is the valve type. Mechanical valve. Reoperation is often the only option since valve-in-valve TAVR is not really performed for mechanical valves as it is for biprosthetic valves. For biprosthetic valves, valve-in-valve TAVR is increasingly used for biprosthetic valve failure due to stenosis or regurgitation and is preferred in select patients who are higher surgical risk. Second, you look at severity of symptoms. For patients with severe stenosis and significant symptoms such as dyspnea, angina, or heart failure, intervention is typically indicated. In cases of asymptomatic patients, the decision may be deferred but requires close follow-up with echocardiography to assess for progression. Third, you look at transvalvular gradients. High transvalvular gradients, meaning a mean gradient of more than 40 millimeters of mercury or more than 35 millimeters of mercury, or a peak velocity of more than 4 meters per second in echocardiography, especially if there's reduced valve area, indicates severe stenosis of the aortic biprosthetic valve that likely requires intervention. For impaired LV function, which is the fourth thing you look at, if the patient has reduced LVEF secondary to severe stenosis, then prompt intervention may be warranted to prevent further deterioration. Fifth thing you look at is the patient's surgical risk. For patients with high surgical risk due to age, frailty, or comorbidities, valve-in-valve TAVR may be preferred over reoperation because it is less invasive and associated with lower morbidity and mortality. For patients with lower surgical risk, reoperation may still be considered, especially if there are concerns about residual stenosis or complications post-TAVR. Sixth thing you look at is the prosthetic valve size. If a patient has a small bioprosthetic valve, valve and valve TAVR may lead to patient-prosthesis mismatch or elevated post-procedural gradients. In these cases, reoperation with a valve-sparing procedure such as root enlargement may be more beneficial. For patients with appropriately sized bioprosthetic valves, valve and valve TAVR is usually more favorable. The next thing you look at is aortic annulus and coronary obstruction risk. For valve and valve TAVR, evaluating the risk of coronary obstruction is critical. If the valve leaflets are at risk of obstructing the coronary arteries post-TAVR and causing ischemia, the operation by surgery may be a safer option. Advanced imaging, such as with CT angiography, is often performed to assess this risk before valve and valve TAVR. Then you look at previous surgery or interventions. Patients who have had multiple prior sternotomies or other surgical interventions may benefit more from valve and valve TAVR, as reoperation carries higher risk in these patients. Finally, in the case of endocarditis, reoperation is preferred if bioprosthetic valve stenosis or mechanical valve stenosis is caused by or complicated by endocarditis, because the infected tissue needs to be removed either way. To summarize, advantages of valve and valve TAVR for prosthetic valve stenosis are that valve and valve TAVR is less invasive, avoids sternotomy, has lower immediate post-operative risk, and is suitable for high-risk surgical patients. Disadvantages of valve and valve TAVR for prosthetic valve stenosis are that there's potential for residual gradients in small valve sizes and the risk for coronary obstruction and valve thrombosis. How about for reoperation? The advantage of surgical reoperation for bioprosthetic or mechanical valve stenosis are that it allows for placement of a larger valve, reducing the risk of patient-prosthesis mismatch, can address infected tissue in the cases of endocarditis, and may provide longer-term durability in younger patients. Disadvantages of surgical reoperation for prosthetic valve stenosis are that there's higher perioperative morbidity and mortality, particularly in high-risk patients, and longer recovery time. The indications for intervention in prosthetic valve stenosis are as described above already. In a patient with severe prosthetic aortic valve stenosis who is asymptomatic, you can send them for an exercise stress test. The inability to augment systolic blood pressure by 20 millimeters of mercury or the development of aortic stenosis symptoms during the exercise stress test are indications for intervention for patients with severe prosthetic aortic valve stenosis who are asymptomatic at rest. Now that we have a good understanding of this, let's turn to the 2020 AHA-ACC valve disease guidelines and hear what they have to say about intervention for prosthetic valve stenosis. In patients with symptomatic severe stenosis of a bioprosthetic or mechanical prosthetic valve, repeat surgical intervention is indicated unless surgical risk is high or prohibitive. That's a Class 1 recommendation. For severely symptomatic patients with bioprosthetic valve stenosis and high or prohibitive surgical risk, transcatheter valve and valve procedure is reasonable when performed at a comprehensive valve center, Class 2A. In conclusion, valve and valve TAVR is often favored in higher risk patients with bioprosthetic valve stenosis who are symptomatic and have suitable anatomy for the procedure, whereas reoperation remains the favored approach for patients with mechanical valves, complex anatomy, or significant risk of complications with valve and valve TAVR such as coronary obstruction or residual high gradients. Then, there is the special case of prosthetic valve stenosis that is caused by prosthetic valve thrombosis. What do you need to know about managing that? The 2020 AHA-ACC valve disease guidelines say, for patients with significant bioprosthetic valve stenosis attributable to suspected or documented valve thrombosis, oral anticoagulation with a vitamin K antagonist such as warfarin is reasonable. That's a Class 2A recommendation. In patients with suspected or confirmed bioprosthetic valve thrombosis who are hemodynamically stable and have no contraindications to anticoagulation, initial treatment with a VKA is reasonable, Class 2A. For bioprosthetic valve thrombosis, surprisingly, 30 days warfarin will do the trick if the thrombosis is causing New York Heart Association 1 to 3 symptoms. Repeat imaging will show that the thrombus has gone away. Surgical valve replacement or thrombolytics are only indicated in bioprosthetic valve thrombosis if it is causing New York Heart Association class 4 symptoms. So what do we need to know about this thrombolytics or surgical valve replacement? The 2020 AHA-ACC guidelines for valve disease say for a patient with thrombosed left-sided mechanical prosthetic heart valve who present with symptoms of valve obstruction, initial urgent treatment with either slow infusion, low-dose fibrinolytic therapy, or emergency surgery are recommended. That's a class 1 recommendation. Factors favoring fibrinolysis to treat prosthetic valve thrombosis are if there's no surgical expertise available, if the patient's high surgical risk, if there's no contraindication to fibrinolysis, if it's a first-time episode of valve thrombosis, if it's New York Heart Association class 1, 2, or 3, if it's a small clot of less than 0.8 centimeters square inclusive, no left atrial thrombus, if there's no or mild CAD, no other concomitant valve disease, the thrombus is clearly visualized, and patient choice. These are the factors favoring fibrinolysis to treat prosthetic valve thrombosis instead of surgery. Factors favoring surgery to treat prosthetic valve thrombosis instead of fibrinolysis are if there's readily available surgical expertise, if there's low surgical risk of the patient, if there's a contraindication to fibrinolysis, if there's recurrent valve thrombosis, New York Heart Association class 4 symptoms, if it is a large clot more than 0.8 centimeters square, if there's LA thrombus, if there's concomitant coronary artery disease in need of revascularization that could benefit from CABG, if there's concomitant valvular disease, if there's possible pannus, or patient choice. These are factors favoring surgery to treat prosthetic valve thrombosis. Thrombolytics for prosthetic valves are effective in 82 patients and have a 6% acute mortality. So these are important factors to consider. And of course, needless to say, fibrinolysis versus surgery to treat prosthetic valve thrombosis is on top of the warfarin, which we assume you have already started on the patient. Routine annual echo is not indicated for mechanical prosthesis with normal post-operative baseline exam and no signs or symptoms of valve dysfunction. The guidelines only allow for echo 5 to 10 years post-bioprosthesis and then annually thereafter. Although in practice, nobody really waits 5 to 10 years to repeat these echoes. That was a very heavy episode. I hope that everything makes sense.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.reohu.com/meded.